My name is Monirul Islam, and I am an associate professor from Augusta University, and I am part of the HELP team of our Georgia Colorectal Cancer Content Program. Dr. Doug Patton and I will be serving as co-facilitator of this TeleECHO session today. So that we can get to know each other, please indicate in the chat your full name and location of your clinic, your role at the clinic, and your email address. You can see an example in the chat session. First, let me review today's agenda with you. Lorian, all right, thank you, Lorian. We'll begin with introductions, followed by our didactic presentation by Dr. Nayak Kapoor, an associate professor of medicine, Augusta University Division of Heme Oncology, Department of Medicine. We also have Drs. Oriambo, Ibrahim, and Amin managing the controls. And now I will introduce Dr. Doug Patton, who will take over today's session. Dr. Patton is the Dean of the Southwest Georgia Regional Campus of the Medical College of Georgia, and he has spent most of his career as a rural physician. Dr. Patton is yours.
Thank you so much, Dr. Islam, and welcome everyone to this session. It's good to see familiar names and faces as we look up at the screen, as we're getting used to seeing each other again, at least on this monthly basis. We'll start, as we always do, with some reminders about the origins of Project ECHO and some basics about that. So ECHO stands for Extension for Community Healthcare Outcomes. And the tagline is moving knowledge instead of people. Our goal here is to spend an hour together once a month, learning from each other, so that wherever you are, you can provide better care for the patients based on the learning that we share with each other. Next slide. A few reminders that these sessions are recorded, as we previously heard, and that by participation up to this point, you're consenting to being recorded. Remember that this is an educational session and not a protected consultation, so please be careful not to mention anything that would be PHI related in our discussions. Obviously, you can ask questions at any time along the way, either in the chat, or you can email us later at au_crcscreening@augusta.edu. Next slide, please. So we do collect data as a part of Project ECHO, and that begins with registration, carries through the program itself, including any audience response questions, responses to survey, anything along those lines. We use this data to create reports, maps, and of course it's shared with Project ECHO back in New Mexico at the hub itself. This helps us not only to track what we've done, but also to plan and inform new initiatives and to make each and every session that we do better for you, the participants. Next slide, please. Just general reminders. Again, we've been doing this a lot for the last couple of years, but it always helps to remember to mute when you're not speaking, to unmute when you do speak. You can always type in a comment or a chat or a question in the chat at any time throughout the presentation. During the open question and answer sessions, if you would have a question or a comment, please raise your electronic hand, and you do that by hovering over the reactions button in the bottom bar of the screen. You'll notice a raise hand icon. Click on that. We'll identify you and acknowledge you, and then ask you to introduce yourself before you share your comment or question. Again, a general reminder, keep your camera on if at all possible, so that your face is visible. This is how we get to know each other. And it always helps to make sure that the lighting is good so we can actually see your face. It's suggested that you use the gallery view so they can see as many participants as possible in the meeting along with the presenter's information. You can always enter in question or a comment about technical issues to Dr. Ibrahim or Dr. Odiambo in the chat. Next slide, please. At this point, it's my very distinct privilege to introduce Dr. Aisha Nayak Kapoor, who is the co-leader of the gastrointestinal cancer program at the Georgia Cancer Center. She's a professor of medicine at Augusta University and has been a principal investigator in a number of clinical trials related to colorectal cancer. Her talk today will be on screening and prevention of colorectal cancer. The presentation will last about 20 minutes. And then after that, we hope to have a few minutes for questions, to respond to your questions in the chats or comments in the chat, but also maybe to even have some live questions from you, the participants. So with that, Dr. Nayak, I turn it over to you, and thank you for presenting today.
Thank you. Can we start the slides, please? Okay, I want to thank everyone for being in the audience, and also for the organizers to give me this wonderful opportunity to meet with all of you and, have this talk today. So I just wanted to bring this whole idea of colorectal cancer, which is such a common cancer that I see on a daily basis. And some few numbers here, if you combine both colon and rectal cancer, which is basically a same entity because it's in the same organ system, we have around 150,000 cases, new cases that we see in this country every year. So it's a fairly common cancer. The interesting fact is the rate at which people are being diagnosed with colon and rectal cancer each year has significantly dropped. And this drop has been happening since the mid-1980s. And a large part of it is related to patients getting screened. So screening plays a very important role in decreasing the incidence of colorectal cancer. And some of it is also related to lifestyle-related risk factors that are being modified with education that we provide to our patients in the primary care setting or even in oncology clinic. And if you look at the numbers, it's a fairly significant number. The incidence rates have dropped by about 1% each year. But the downside of all of this is, though the trends are decreasing, this trend is largely among the older adults. And when I say older adults, I mean those that are 50 and above. But what we are seeing, which is not a good thing, and we don't know the reasons for that, the trend of colorectal cancer has increased and is increasing by 2% in people younger than 50 years of age. And also it's increasing to some degree in people between age of 50 and 64 years. So being young no longer is protecting anyone from colorectal cancers. Can we see the next slide? So this is a beautiful picture here showing a graph of how the incidence is decreasing among the older patients 65 and above. But as you can see in the below numbers here, in patients less than 50, the trend is actually on the upswing. And if you look at these people between 20 and 34 years, there is a significant increase in the trend of colorectal cancer, especially in the left-sided colon cancer. We are seeing a significant increase in the numbers. Can we see the next slide? So this is just to stress the fact that the incidence of colon cancer in the younger population is increasing, and it is increasing at a rate of 124%, especially in the left-sided cancers and in the rectal cancers. Next slide. So what is the lifetime risk of me getting colorectal cancer? It is about 4.3%. So 1 in 23 men will get colorectal cancer, and 1 in 25 people women will get colorectal cancer in their lifetime. Next slide. So what are some of the risk factors? We can divide the risk factors into modifiable risk factors and non-modifiable risk factors. The modifiable risk factors, and a lot of this can be toned down and changed with education. Being overweight or obese is a big modifiable risk factor. Not being physically active, certain type of diets that are rich in fats, smoking, alcohol use, these are some of the modifiable risk factors. Next slide. So when we talk about the risk of getting colorectal cancer, we can divide the population into two major risk groups. One is the average risk population, and other is the high risk population. What is the average risk population? Average risk population is ones who do not have any of the ones that are listed on this slide. They have no personal history of colorectal cancer or certain type of polyps. When I say certain type of polyps, I mean patients who have, small polyps, less than 1 centimeter, who have a polyp that is hyperplastic and does not have a tubulovillous architecture, or those who have a polyp that is not serrated or flat. These are some high-risk polyps. A family history of colorectal cancer should not be there. A personal history of inflammatory bowel disease, which is ulcerative colitis or Crohn's disease, should not be there. Or any of these hereditary colorectal cancer syndromes like FAP, which is familial adenomatous polyposis, or Lynch syndrome, HNPCC should not be there. And any history of getting radiation to the belly or abdomen or pelvic area related to a prior cancer. If any patient has any of these risk factors, they're not average risk and they are high risk. Next slide. So these are all the patients who I would consider as high risk for getting colorectal cancer. And the interesting thing is, we need to start screening patients who are at a high risk, definitely at an age before 45 years of age. They need to be screened more often. And any of the patients who meet these criteria, they need to be start their screening at an age before 45 years of age. Next slide. Now, these are some of the non-modifiable risk factors that we see: being old, and having any personal history of all these diseases, having any inherited syndrome. Racial and ethnic background does play a big non-modifiable risk factor, and having type 2 diabetes is another non-modifiable risk factor. Next slide. So for average risk population, the current guidelines are based on American Gastroenterology Society, the UPSTF guidelines, American Cancer Society guidelines. We should start regular screening at the age of 45. It used to be 50 before, but now it has been cut down to 45. Now, when should you stop screening people for colorectal cancer? I believe anyone who is over the age of 85, we should no longer consider doing colorectal cancer screening. Now, patients who are in good health and have a life expectancy of, I would say, more than 10 years, you should continue regular colorectal screening through the age of 75. What about patients between 76 and 85? Again, the advice whether to do screening or not will be tailored based on preferences, life expectancy, their overall health, and of course, it will be a communication between the patient and the provider whether they should be advised to have the screening. Next slide. So what are some of the testing options that are available for colon cancer? You can do a direct visualization screening, and those include colonoscopy, a virtual colonoscopy. The first one that I say here, colonoscopy, is a visual colonoscopy, which the GI endoscopists do. Then you have the CT colonography, which is called the virtual colonoscopy. Then you have the flexible sigmoidoscopy, which is only going to look at the left side or the distal 60 centimeters of the colon. Then you have certain stool-based tests, which is called the fecal occult blood testing or GUAC fecal occult blood testing. Then you have the stool DNA tests. And then you have what's called the FIT or the fecal immunochemical tests. There is also the availability of blood tests, and we'll talk about that briefly. But again, the sensitivity and the specificity to pick up a malignancy or even pre-malignant lesions is very low with the blood test. Next slide. So again, there is really no best strategy for colorectal cancer screening. Colonoscopy, the visual colonoscopy, is believed to be the gold standard and the best strategy. But whichever strategy that is being offered to the patient and the patient is comfortable moving forward with, the patient needs to adhere to that particular screening test consistently. That is very, very important. Can we see the next slide? Okay, there's a term called programmatic screening. What that means is that any screening, it should involve a repeated testing over a person's lifetime. And it should not be, and the patient need to be educated. There are a lot of patients who come in and say, I've had testing done. Do I need to have it repeated? No, the answer is they need to be repeated, and that's what's called as a programmatic screening, and that's very important. Next slide. Okay, I know this is a very busy slide, and there's a lot of things that are written here, but I will go over it quickly and briefly. This is a slide that is comparing the various different screening strategies that we have available. This is a slide I took from New England Journal of Medicine that's looking at the first test is the GUAC, which is the fecal occult blood testing and the fecal immunochemical testing. It has effectiveness of reducing the mortality by 32%. There are multiple randomized controlled trials that have shown the mortality reduction benefit with these tests. The interval recommended is annual, and it is, of course, all screening tests are cost effective because once anyone develops malignancy, the treating that malignancy is highly, highly expensive. We know that. So it is very cost effective and it is very convenient. It can be performed at home on the cards that are provided to the patients. And its ability to detect precancerous neoplastic lesions is not that good. It is not very reliable in detecting the precancerous neoplastic lesions or pre-neoplastic lesions like polyps, because the shedding of the blood is not that good with pre-neoplastic lesions. The next test is the flexible sigmoidoscopy, which has a 27% effectiveness in reducing the mortality from CRC. There are various randomized controlled trials have shown a mortality benefit, recommended to be repeated every 5 years. It is again cost effective, and advantage is a limited bowel prep is needed, unlike for a complete colonoscopy where you need a complete and a very good bowel prep. And it is effective in detecting precancerous neoplastic lesions. So one can combine flexible sigmoidoscopy with FIT, which is fecal immunochemical testing. It has a 38% effectiveness in lowering the mortality. And there is one randomized controlled trial that has shown that combining flexible sigmoidoscopy with FIT reduces cancer mortality more than sigmoidoscopy alone. Makes sense. And the interval for repeating this test is you could combine both of them and repeat it every 10 years interval. Cost effective again, and it can detect precancerous neoplastic lesions. Now there's another test called FIT DNA. This has unknown effect on mortality reduction, but there are studies that have shown really that the studies have not shown a significant mortality reduction benefit, or studies have not been done so far. The fit DNA is expected to be repeated every 1 to 3 years. It's less effective and more costly than the fecal guac or FIT or colonoscopy. And it can be performed at home because it's a fecal test, and it does not reliably detect precancerous lesions. About colonoscopy, we know it has the best effectiveness in reducing cancer mortality. It has a 68% effectiveness in lowering cancer mortality. There have been prospective cohort studies shown the mortality benefit. The frequency is every 10 years. It is cost effective, requires a full bowel prep, and requires sedation. And of course, you need an escort to take you home after the procedure because you're going to be sedated by anesthesia. It's very effective in detecting precancerous neoplastic lesions. The next one is CT colonography, which is radiology. You have to have a trained radiologist to read this study. It has an unknown effect on reducing the mortality of colorectal cancer, and data from studies showing a mortality benefit are lacking. It's supposed to be done every 5 years. It is less effective and more costlier than either colonoscopy or fecal occult blood or fecal immunochemical testing. Advantages: no sedation is needed. Of course, it can detect precancerous neoplastic lesions. The last test here is the blood test that I was talking about, which is checking the blood for circulating methylated SCPT9 DNA. Again, has really no known effect on reducing the mortality. And interval, we do not know. This is still early, and we cannot really comment on its cost effectiveness and its interval. And again, it's a blood test, so it's expected that patients may be more adherent to this test. Again, not a very reliable test in detecting precancerous lesions. Next slide, please. So we all know that case control and prospective cohort studies have estimated that doing a colorectal cancer screening can reduce the mortality by 68 to 88% patients. And the gold standard still remains colonoscopy, because if any of these prior tests turn out to be positive, you eventually have to follow it up with colonoscopy. Next slide. So talking a little bit in detail about the fecal screening tests, we have two broad categories that we touched upon. Those that detect the blood from ulcerated colonic mucosa resulting from cancer or large polyps, and those that detect molecular markers that are shed from cancerous epithelial cells. Now, fecal occult blood tests include two types, the guac-based test and the immunochemical test. And both are primarily an early detection screening test. And there can be some variation in sensitivity of the fecal test, or it could be limited sensitivity because cancers bleed intermittently. And the current guidelines recommend repeating this test every year or every other year. Next slide. So fecal immunochemical test, as you know, is a test which uses antibody against fecal hemoglobin, and one does not have to adhere to any dietary restrictions as with guac testing. One does not have to be having any restrictions at all, actually. And again, there are certain sensitivity rates here of approximately 79% and a specificity rate of around 94%. And, it is recommended it's repeated every 1 to 2 years. And we know if it's positive, you have to eventually follow it up with a colonoscopy. Next slide. So FIT DNA is something that is looking at molecular markers, including abnormal DNA from cancerous cells that can be detected in the stool. And FIT, which is fecal immunochemical testing, combined with the stool DNA, which is the FIT DNA, it has been approved by FDA, and studies have shown improved sensitivity and specificity if one does FIT DNA. And the data from studies evaluating the benefit in reducing the mortality, they are still lacking. Next slide. So a little bit about flexible sigmoidoscopy. We know it is only going to look at the left side of the colon. And again, there have the mortality benefit in several large randomized controlled trials have confirmed that, there is some benefit, but not all trials have shown a benefit in improving the mortality. Next slide. So colonoscopy, which we all feel is the gold standard, there have been numerous studies done, case control and prospective cohort studies have shown that it does decrease the mortality. And there are various studies that have shown, most have shown improvement in mortality benefits, some have not. And I guess that is largely related to incomplete colonoscopy from a poor bowel prep. There are certain polyps called sessile serrated polyps, which are flat polyps, and they may sometimes be missed on colonoscopy, and they may contribute to, they can eventually progress on to malignancy, and that may also add to, in some cases where the mortality reduction has not been seen. Next slide. So radiographic tests have, that we talked about, which is CT colonography, has been done. The problem with this test is not all radiologists are trained enough to read these tests. And you have to have a polyp of a certain size, which is generally a 6 millimeter in diameter or larger, to prompt its detection on the optical colonoscopy, or what's called as the CT colonography. And it does involve a lot of exposure to radiation. So I mean, we don't have it here at AUMC, and I have not seen anyone having had it done. I think only indication would be if patient is completely averse to any other screening test, one can consider doing it. But again, you need to have radiologists trained to read this test. Next slide. So this is about the blood-based tests for screening, and the FDA has approved a blood-based colorectal screening test, which detects circulating SCPT9 DNA, which is a circulating methylated septin 9 gene. And as I alluded to earlier, the colorectal cancer mortality benefit from doing this test is still lacking. And there was a prospective study conducted in a screening population where they used colonoscopy as the reference standard. And it was found that this blood test has a sensitivity only of 48.2% and a specificity of 91.5%, a positive predictive value of 5.2%, and a very high negative predictive value of more than 90% for detection of colorectal cancer. Next slide. So I think the bottom line is that one has to be adherent to the frequency that is recommended, and follow the guidelines, and that is what should be recommended to patients. Unfortunately, the percentage of US people who have up-to-date screening for colorectal cancer has not increased appreciably. It could be better, it has increased, but it still remains at 60%. And I think the goal should be to get it at least up to 90% and above. And, and the number of patients undergoing flexible sigmoidoscopy is apparently less than 1%, which I think is really very dismal. Next slide. There are a lot of barriers to screening that we need to overcome by education. The most important of them is having or not having adequate health coverage. There are other barriers like underappreciation of the effect or severity of colorectal cancer. I think the general population does not understand or are in denial that once you have the cancer, how hard it is to treat these patients with various surgical procedures and chemotherapeutic agents. There is a huge element of fatalism, and they just don't perceive it as important, and they're very fearful of screening tests. I think education goes a long way in understanding, making them understand. And this, I think, the next slide, please. The next slide, I think, is just telling us about the screening frequencies and what are the different societies and task forces that are available that tell us when and how frequently we need to advise the screening procedures that we talked about. Next slide. These are certain areas of uncertainty. I think this is my last slide, which is looking at clinical trials that are comparing the available screening modalities. There's this trial that's looking at colonoscopy versus fecal immunochemical testing in reducing the mortality from colorectal cancer. There's one trial that is in Spain looking at comparing colonoscopy with fecal immunochemical testing. There are a couple of European trials that are, again, looking at screening colonoscopy with no screening, which is kind of, I think we have already proven that in our country that it is very helpful in decreasing the mortality. So I think this is probably my last slide. Thank you. If you have any questions, I'm happy to answer them for you. I'll try to answer them for you.
Thank you, Dr. Nayak. That's a wonderful and comprehensive review of all of the screening tactics, including some of the ones that are considered controversial. But I appreciate more than just the general reminder that even the ones that may be considered to be less effective, if that's the one the patient can get, that's the one that we should offer. So what questions do we have for Dr. Nayak from the participants? We've got folks from the coast to the Chattahoochee, all the way across the state. Let's hear from someone. Dr. Hotz.
I just wanted to make one area of clarification. I'm on the National Colorectal Roundtable, and one of the challenges we have is doing a randomized control trial for FID and fecal DNA because the ethical concerns about, as the good doctor mentioned, how do you do a trial, on a test that works and then have somebody not get the test? The 38% reduction that was quoted was a randomized control trial by Dr. Jack Mandel in 1993 showing FIT guaiac tests, which are not as good as the FIT test or the fecal DNA, reduced mortality 38%, and that was every 2 years. To address this, the U.S. Preventive Services Task Force, to make a recommendation about the FIT and fecal DNA, contracted Dr. Zauber from Sloan Kettering to do modeling studies. And these modeling studies showed that if adhered to every 10 years, the number of people per 1,000 who died of colon cancer after the age of 45 with colonoscopy done every 10 years was 7, and with the FIT testing every year was 8. So if you look at population management, it's about the same. Now, these are modeling studies, there are pros and cons, but that was the basis of that recommendation. Now, the question I would like to ask, one of the challenges is that these studies are all recommended, FIT tests and all that for average risk. And I'd ask the doctor, what % of people in a population are average risk? I've seen quotes as the high risk goes from everywhere from 10% to 30% if you throw in polyps.
I think in my experience, 85% patients belong to the average risk population, and 15% of the patients are high risk. And yeah, that's the kind of breakdown that I see in our practice over here. 15% are high risk. And in those patients, again, the high risk, actually, it's very interesting that you bring that up. There are a certain group of patients who really should undergo what is actually called as, a much, closer, I think we need to assess what makes them have the high risk. Is it the family history? Is it just having polyps? Is it cancer syndromes? And the screening approach, I think, needs to be changed based on that. And as you know, there is a thing called as enhanced screening. Now, enhanced screening is something where you have any of these patients have personal history of colorectal cancer, advanced adenomas, advanced serrated lesions. And, if one has one or more first-degree relative who has been diagnosed at any age with colorectal cancer, the screening needs to begin. That's what the literature says, 10 years before the first-degree relative's diagnosis. Now, if somebody has a familial colorectal cancer syndrome, like Lynch syndrome or FAP, now with FAP, we know that their chances of conversion into colon cancer is as high as 100%. Depending on what age they present to you, I think that more than screening, one should recommend them to have a complete total colectomy. So I think that it's based on every case-by-case basis, and a lot of it depends on the motivation of the patient and a certain degree their education level also, and I think there are a lot of social factors that also play a big role in how we proceed with each one of them. But I will tell you that we do have a wonderful genetics clinic at the cancer center here. It's run by Dr. John Henson. And every patient who is a young age onset colorectal cancer, I mean young, anyone 50 or less, we are referring each and every patient to the genetic counseling clinic where Dr. Henson is doing a blood test on them to ascertain if they are or could be the index case for onset of a familial disease. So I think that is that's an interesting thing. And the other thing that concerns me is, though we have reduced the age for starting the average risk patients colonoscopy age, we are seeing so many young people coming in with colon cancers at 30, 35, 40, especially left-sided ones. I mean, how can we prevent them from getting colon cancer? Should we even further reduce our age of starting screening on these patients? So these are some questions I have no answer for. And if we can have a dialogue on that too.
Thank you.
Thank you, Dr. Nayak. I see that we've got at least one other question in the chat. We'll hold that for now because I want to go ahead and make sure we have plenty of time for our case presentation, and we'll try and get back and visit that later. So at this time, it's my pleasure to introduce Dr. Floyd Soriano, who's from East Georgia Healthcare Center in Metter. And we all know it's better in Metter. And he's going to present today's case study titled Data Overview and Barriers to Screening Success for Colorectal Cancer for the East Georgia Healthcare Center. So about 10 minutes for the presentation, and then we'll have some time left over for questions for both Dr. Soriano and maybe some follow-up time back for Dr. Nayak as well. Dr. Soriano, thank you for sharing with us today.
Sure, thank you for having me, Dr. Patton. Well, this is less of a case presentation, but more of a status report from the primary care trenches and just to let you know how we're doing with the CRC screening program. Next slide, please. So this is just an introduction of our workflow and how we start. My nursing staff and I kind of review the charts, prep the charts, and rely on our electronic health record to alert us as to which patient are eligible for screening. And if we don't have that information, we're directly asking them, at triage. And sometimes we didn't get a colonoscopy report from other physicians. And we've actually went ahead and our medical assistants are already dispensing the kits, right off the bat. And if we're encountering some resistance, then I tend to come back later in the exam room and ask patients to address their concerns and hopefully convince them to do the screening. Next slide, please. So this is our Medicare clinic started in March, and this is the compliance rates. So hopefully we're increasing our rates a little bit as time goes along. And like Dr. Nayak was saying, we're trying to get to 60% and hopefully 90% by the time, pretty soon, hopefully. Next slide. And this is our kind of accounting on how many tests we've given. So initially we had a pretty good amount, 45%, but kind of tapered off in the summer. But why is this happening? So next slide. So this is a common barriers. It's well studied in the literature as far as why patients are not wanting to get the screening done. First is fear and worry, because they don't want to know if they have cancer. So, and it's just they'd rather not know. And even the patients that I spoke to, next item is that they're not having any problems. They're not bleeding. They're not hurting. So why look for things? And then there are also financial concerns. With the program, we're trying to use the FIT testing or the HemoSure testing. So there's not really a financial concern, but some of them are a little confused about whether they're going to have a colonoscopy, and discuss with the procedures that, I'm going to have to collect my own stool and send it off in the mail or bring it back. The logistics part is having to come back to bring the sample, and some of them forget that they even got the test. So next slide, please. So how do we overcome the barriers? So I kind of lumped these first two here. Early detection is key with colorectal cancer, because the earlier you detect it, the earlier the stage, and more likely that they'll survive longer or even achieve cure. And as far as the next three items, I mentioned that the FIT testing, some patients think that they're going to have a colonoscopy, and all the different concerns about that, the cost and co-insurance and co-pays. But we have to explain to them that the FIT testing is cost effective and would really serve, the yearly FIT testing would prevent them from needing the colonoscopy. Next slide. And the grant also allows for patients who have a positive test to get colonoscopy, and was working with Dr. Desai to see if we can get some of the other colonoscopists, GI or surgeons in the area to be involved in the project, and hopefully some of our financially challenged patients can get a colonoscopy, a diagnostic colonoscopy. Next item is if they're worried about it's going to be difficult to do the test, our MAs actually, go over the kit with them and how to collect the sample and how to send it back. And we're trying to get the navigators to follow up with the patients and just to remind them, hey, you got the HemoSure test, and this is how you collect it. Do you have any questions? And if they're not wanting to come back and bring the sample, they could just mail it. They have already prepaid the postage. The next item. Next slide, please. So in conclusion, just like Dr. Nayak was saying, it's our duty to educate our parents, our patients, so that we can improve our screening rates from 60% and beyond, because early detection at an early stage can lead to 90% survival rate and many times cure. So anyway, that's it for my presentation. We'll open up back up to questions. Thank you.
Thank you, Dr. Soriano. That's very helpful. And I just want to call attention to one of the comments that was made. When your goal is 60% and you're still hovering in the 30s and that sort of thing, it's a little easy to feel discouraged. But as Dr. Hotz pointed out, a 4% increase over that short a period of time is a significant increase. And so congratulations on that. I know that others are seeing progress with that as well. Do we have another question right now? I don't see any hands raised. Dr. Islam.
I wanted to thank you for Dr. Soriano for presenting his case. As Dr. House and Dr. Patton mentioned, 4% increase, which is remarkable. Thank you for that. My question is to you, what the difference arrangement you made from 30% going to 34, 35%, the difference work you did, whether there is a room for improvement, those activities that can make better and continue the trend that you have. Is there anything that in the clinic you make differently that makes this huge difference in terms of the colorectal cancer screening rate?
I think what we've done is doing a better job with chart prep and communicating with my staff, and also when there is a static from the patient, I kind of step in later and kind of ask them, oh, how come you don't want to do your HemoSure test? It's it's an easy test, and at that point I can address the barriers to for them to make that decision.
That's wonderful. Thank you.
Dr. Soriano, that gets to one of the questions that was in the chat from Mary Beth Curtis. She was trying to focus in on that patient experience and trying to conduct the home stool-based test. Obviously, the FIT is cost effective. It is relatively easy, but it's also problematic. And she mentioned even specifically sometimes the paper tears and then the stool falls down in the bowl. How do your navigators have any specific tips on how to coach patients through to successfully collect and easily collect these specimens?
Well, I'll be honest, but I haven't really heard of any problems for my patients that collecting it or tearing through. Mostly that they never do it. They never send it back, or they forget, or they just don't do it. So
Okay.
I'm not sure anybody in the audience that might have an answer for it.
Well, Dr. Hotz has his hand raised. He always has
Okay.
a thought.
Yeah, having done this a long time, that's one of the things navigators do. If they make a mistake, if they lose the kit, they send them another one. Part of it is once, and here's a subtle piece that it's always great to have an oncologist talk, because they see the Lynch syndromes, they see those families, they see the tragic, and they also see the advanced disease. And once we have said that their average risk, okay, and remember 15% aren't, so Another thing in the future meetings we probably need to do is figure out how do we, put that in the chart so that we're not giving fit tests to people with Lynch syndrome. But once we have said their average risk, then the navigator is free to, do whatever it takes to get that fit test back. They can't just mail out a fit test to anybody in our population because fit is not appropriate to 15% of the people we have. And so, that's one of the reasons I asked that specific question. But that's one of the great things about navigation. You don't want them to come back to Dr. Soriano and say, oh, well, my tissue, that's what the navigation is to do. Now, when we've done the navigation and we iron out the kinks in the practice, we get about a 70% return rate, which is outstanding. Without that, all of us who've not had navigation, it's 30, 40%. It can be frustrating. But, that's our job as clinicians, is to say, this is an average risk person, we give the test. And then the navigator's job is to get it back.
Thank you for that, Dr. Hotz. Dr. Amin, you had your hand up.
Oh, yeah, I was just, well, it was piggybacking on what Dr. Hotz was saying. Dr. Soriano, thank you so much for your presentation. I just wanted to, I'm Sable's counterpart on the East at AAPHC and Horizons Community Solutions. So Horizons are actually the patient navigators for all of the HemoShares for the East. And I just wanted to get your feedback, I guess, on how you feel. Obviously, your numbers are doing great. And, although it seems low, that, you guys are going up pretty quickly. And we're hoping that once the COVID bump goes down, then we'll see an even bigger increase. But just on your end, from your point of view, do you have any feedback as to how the Horizons navigators are going about and getting these tests back? Are you seeing any feedback from patients or anything like that on your end?
Not yet, but I think we're going to try to explain to patients that there is a navigator facilitator that would be calling them and not be concerned about, that it's a telemarketer. And I've started doing that so that, they'll wait for a call and maybe it's a secondary reminder, that maybe they'll encourage them to do the test more. So,
yeah, because one question, a little follow up for that is just because we're seeing on the East that a lot of patients, they habitually refuse to get testing done. And so what some providers are doing here on the West is they're saying, here's the test. Can you talk to a navigator and see, and if you, after learning more about the exam, because obviously most of the time they listen to providers, but having someone from the community explain it to them seems to have helped here. So that's why I was just kind of seeing if that's making a difference, but I guess it is kind of early in the process to see if that's making a difference. But I guess for education purposes, because I know for the younger age group, the 45 to 50, we're hoping that that makes a bigger bump in terms of education for that age.
Thank you for that. Dr. Odiambo.
Yes, thank you so much, Dr. Soriano. My question goes back to Dr. Nayek's presentation. I'm just curious, looking at the clinical trials and the fact that these trials set the trend or the recommendations for the whole globe pretty much. What could you say about participation when it comes to countries from low, middle income countries and so on? Do we have participation from African countries and so on? Because we see trials in Europe, we see trials in the US. Do we have anything ongoing in Africa, and what countries do participate?
Dr. Nayek, you still with us? Did you hear the question?
Hi, can you please repeat it?
Yes, I was just curious about the representation of low, middle, and middle income countries in some of the clinical trials that are leading to some of the recommendation for colorectal cancer. We see a lot of trials in the US, we see trials in Europe and so on. So how about Africa, sub-Saharan region, and the Middle Eastern region? Do we have representation in those areas?
I can actually look into that. I do not have much knowledge about what percentage of patient screening population is coming from those countries. The studies that I have looked at, and the one that recommends colonoscopy as showing reducing the mortality from CRC, that was, I believe, done in US. So I do not know if there have been any international studies looking at other not so well endowed countries. Honestly, I do not know.
Thank you for that.
Thank you.
Question, Dr. Odiambo, and for that response, Dr. Nayak. I think, we look at the disparities in rates of colorectal cancer and death rates. And it seems like in some of the poorer countries, the colorectal cancer rates may be lower, but that may be a reflection more of the other types of diseases that those communities face, as opposed to some of the things that we can tackle here. Well, we're gonna call it a day at that, and I'm about to turn over to Dr. Islam, but I want to thank everyone, and I just noticed I have to say this in the chat. We've got people from Texas, we've got people from Anchorage, Alaska, we've got people from Chicago. We literally have a nationwide audience participating in this call today in this echo session. So I really, really appreciate that. And on behalf of Dr. Kush Desai, who couldn't be here today because he's getting married Saturday, we want to thank you all for your participation in this. And with that, I'm going to turn it back over to Dr. Islam. Thank you.
Thank you, Dr. Perrin. Thank you, everyone. I wanted to call attention to all audience. Please follow the link link on the chat, or scan the QR code to claim CME and CNE credit for today's session. That'd be wonderful. It's a free to all, so claim that the credit. Thank you again, Dr. Perrin, for leading us through this presentation and discussion. I personally thank you, Dr. Soriano and Dr. Nayak, for their wonderful presentations, and also to all audience today. Moving forward, we will need volunteers to case presentation in our future sessions. If anyone has a particular case, please contact to us via email au_crc_screening@augusta.edu. Our next session in Wednesday, September 7th, 2022. We in fact have session every month, first Wednesday every month till December this year. We'll send information in next 2 weeks for our next session. Thank you everyone for attending. We will see you in our next session. At this time, I would like to thank you again, and the session is adjourned. The TeleECHO team will stay here for post-session debriefing. Everyone can log out. Thank you and have a great day. Goodbye. We're going to wait a few minutes and give everyone time to log off.
Sounds good.